Now I'm going to introduce our next speaker, and our next speaker is Dr. Quoc-Dien Trinh. And Dr. Trinh is an associate professor of surgery at Harvard Medical School, director of ambulatory clinical operations at the Division of Urological Surgery at Brigham and Women's Hospital, and co-director of the Dana-Farber Brigham and Women's Prostate Cancer Center. He is a lead faculty for cancer and comparative effectiveness at the Center for Surgery and Public Health, a joint program of Harvard Medical School and the Harvard School of Public Health. Dr. Trinh's research focuses primarily on inequity and outcomes of cancer care. Dr. Trinh received his medical degree from the University of Montreal in Canada, where he also completed his residency training in urology. He completed his fellowship, minimal invasive urological oncology at a urology institute in Detroit, Michigan. Dr. Trinh.
Hey, thanks,
Thank you for being with us.
Absolutely, and thank you again for the invitation. I always love presenting for PHEN. You know, I've been doing this, I think first time you invited me over was 6 years ago. So always a pleasure. So let me share my screen and let's get started with my presentation that complements Dr. Rose's presentation. So we'll go over some of the things that he talked about in his talk, but through the lens of some of the research I've been doing, and also some of the things that we're about to do in my research team. So these are my disclosures. Importantly, some of this work is done with the Massachusetts Department of Public Health. Some of this work has been funded by the Prostate Cancer Foundation and the Brigham Research Institute as well. So I'm not going to go into too much details of some of the things that have already been mentioned by my colleagues who presented earlier before me. For one, we know that there are racial disparities or at least differences in cancer outcomes. And this is true for prostate cancer, it's true for breast cancer, it's true for bladder cancer, which is another cancer that we treat in urology. What's interesting, and this is a paper that Pong Nguyen, Brandon Mahal, which I'm sure most of you already know, published a couple years ago. But what's also interesting is that there is a gap, we know that, between African American and white patients. But the gap is not the same across all cancers. It's more pronounced for prostate and breast cancer. And also the gap is not getting better. If you look at studies that looked at, let's say, the past decade and the decade before that, you'll see that the gap has gone slightly wider instead of improving, because if you think or hope that access to better health insurance, among other things, would improve equity, well, it doesn't seem to have made things better with regards to prostate cancer in narrowing the gap between Caucasians and African American men. We also know, as Dr. Rose pointed out, and I will show you some data from our group, that in equal access settings, like the VA healthcare system, it seems like there's not as much racial disparities as you think you should see. Thus, the hypothesis that many people are starting to at least appreciate more is that where patients receive care, and just to be clear, I'm not talking about a specific hospital, but at every level, right? Where they're getting their primary care, where they're getting their diagnosis of their prostate cancer, where they're getting treatment for their localized prostate cancer, or even where they get their treatment for their metastatic prostate cancer, those kinds of differences may have a huge impact in this perceived difference between the survival of African American and white men with prostate cancer. So this is an example of a study that we did that was published a couple years ago, 4 years ago, in JAMA Oncology. And we looked at racial differences in surgical care of prostate cancer among the Medicare population. What's different from this study? So, you know, if you look at all these other studies that have shown that there's a difference in survival, what's different about this study is that we only studied people who are covered by Medicare. So by definition, as we know, if you're 65 and above, you have health insurance through Medicare. So there's none of that discrepancy between white patients having super A+ private insurance and individuals of minority not having that kind of insurance or on Medicaid or uninsured, et cetera. So this is only Medicare patients. And these are also people who are only 65 and above by virtue of this study design. What's also important in this study that is different from others is that we only included people who actually went for surgery. And again, I'm not making a case for surgery being better than radiation or anything. It's just that we selected this cohort among only those who had surgery for this study. And what we found, interestingly, is there's actually not much of a difference. There's no difference at all in the outcomes of African-American men versus Caucasian men who are 65 and above, covered by Medicare, who actually choose to undergo surgery. You know, what's interesting about this study, and I remember fondly about the editorial who was written by Otis Brawley on this paper, is that there's two ways to see the results of this surgery, this study. One way is to say that if you provide good access to care, African-American and white individuals will have the same outcomes. And that's one way to see it. And hopefully that's let's say, the optimistic way to see it. But the other way you could see it's also, well, you know, if you're 65 and above and you have prostate cancer, it doesn't matter because, you know, at that point, it's not as important to get treatment or not, which is, I guess, the pessimist way to see that. And you could apply that argument to every setting. You know, when Dr. Rose talks about the outcomes in VA hospitals of African-American and white individuals, the outcomes are the same. The positive is say, provide these individuals with equal access and you will have the same outcomes. The negative way to see it is say, well, in the VA healthcare system, the outcomes are not great anyway, so that's why there's no difference. I obviously abide more by the optimistic hypothesis, or at least I hope, but you know, detractors of these kinds of papers will say, well, you know, in the VA system or in the Medicare population, you're not going to see a difference because, you know, the outcomes are poor regardless, or quote unquote. You know, I'm not going to talk too much about this because Dr. Rose already did, but you know, my biggest funder of my research right now is the Department of Defense. I do research with the military on allocation of complex military surgical care. One of our collaborators actually has published a lot on the topic of racial disparities in the context of the military healthcare system. And again, in this paper, which was published in a really prestigious journal, the Journal of the National Cancer Institute, they found that in the military health system, there was no difference in treatment delays, in this case for colon cancer, between Black and white individuals. And we are doing some additional studies on the similar topic, and we tend to find these kinds of things. And I do want to emphasize that the military health system, as I am talking about here, we're talking about TRICARE beneficiaries who are getting their care at military facilities. That's different from what Dr. Rose was talking about, which is the VA system for veterans, which is a distinct system. But again, equal access setting, military service members and their families getting their care in military hospitals, no difference in processes of care such as delay in treatment for colon cancer in this case. And you know, the examples goes on. There are many examples of studies that have shown that in VA hospitals and military hospitals, no difference between African-American and white patients for outcomes, but even for other metrics such as quality of care, receipt of timely treatment, et cetera, et cetera. This is a paper that we published a year and a half ago that was actually a study that was funded by the Prostate Cancer Foundation, which the organization named one of the provocative papers of that year. And it's somewhat almost like a reversal of what we have previously thought of. And interestingly, this was one of a series of papers from other groups that started coming out around that time, which seems to suggest that what we thought about racial disparities, somehow believing that they're perceiving that there's some sort of biological explanation as to why African Americans have worse outcomes, is that in fact overblown, and there are potentially other explanations for those kinds of differences. So in this paper, we use registry data, and you know, if you look at the curve A, and you see white patients, which is the top line, and then the dashed line is African American patients or Black patients, you see that if you don't adjust or account for other factors, there's a pretty wide gap between the survival of Black individuals and white individuals who are presenting with advanced prostate cancer. But when you look at curve BCD, it's when you start accounting for all these other factors, for socioeconomic status, education, access to care, access to treatment, and how bad the cancer is at presentation, it's like you almost see a reversal of the situation. So whereas if you just do not account for all the other factors, white patients seem to be doing better, as all these other SEER studies have suggested. When you account for all these factors, in fact, in some circumstances, African American patients actually do better if they are provided with the care, and therefore it seems like it's different from what we have thought before. As I promised, at the same time, there were other studies that looked into this question. And in this paper that was published in JAMA Oncology, they use, I believe, SEER registry data and other data, and they seem to point to a similar kind of relationship, meaning if you start accounting for these non-biological access to care type variables, Black race did not appear to be associated with inferior survival across all stage and grade of prostate cancer. So again, another pretty provocative paper that goes against what we have thought or said previously. And then the evidence continues. Other papers came out. This is a study, a retrospective study that looked at the survival by race in patients who are receiving one of these newer drugs that Dr. Pomerantz was talking about, such as abiraterone and enzalutamide. And again, interestingly, against all the wave of previous literature, African American men had better survival when they were treated with abiraterone and enzalutamide than white patients. And again, just to be clear, this is not a trial, this is a retrospective analysis, but it is quite interesting to find that the signal points against previous trends, because like I said, you know, the common thought process was to say African Americans, by virtue of biology, somehow will have worse outcomes than their white counterparts. Another study, again, this is a different setting. It's a prospective study of data collection, but you know, it's not a randomized trial, but among all individuals who were treated here with abiraterone. And again, the study here found that Black men seem to be doing at least equally well, if not better, than their white counterparts. So, you know, if you've taken that into account, you take into account that African American at baseline have worse outcomes, you know, when you don't account for things. But then when you start accounting for this access to care questions, the situation changes and it potentially even reverses in some of the studies, including ours, that were done in the last 2 years. So then the question becomes, well, you know, if that is the case, then maybe it is because African American men are getting their prostate cancer care at certain places, and for whatever reason, again, it's not about blame, but about trying to understand that relationship, it leads to potentially worse outcomes. There are many studies that have looked at how your care can be different depending on where you seek care. And that care can be different according to the state. And this is a paper that we just looked at, state level variation of prostate cancer screening. That's on the left, and you can see on the heat map that it is incredibly different whether you are in Hawaii or New Hampshire, for example. It will vary according to specialty. You know, if you look at that paper that was published on the right in JAMA Internal Medicine, you'll see that following the USPSTF recommendations, urologists didn't really change their prostate cancer screening practices, but primary care physician changed a lot. And it will vary according to other factors, including the hospital where you're being treated, the country, et cetera, et cetera. So this led us to think a little bit more about this question, and this is ongoing work. This is some work, preliminary work that we did, but we're continuing that work at the state level in Massachusetts with the Department of Public Health. Is the idea that maybe depending on where you're seeking your care, there will be some variations in the care you receive. So we looked at different institutions across the country. And we tried to understand, well, among men who should be treated for prostate cancer, right? There's no controversy that if you have intermediate or high risk prostate cancer and you have a decent life expectancy, treatment with either surgery or radiation would be the standard of care. And we wanted to see, well, what's the percentage of white men getting surgery or radiation in that context at a given institution? And what's the percentage of African-American men with that kind of disease getting treated? And what is that difference between white and black men? And what we found is somewhat of an uncomfortable finding to notice that nearly 40% of hospitals will treat more white men than black men with this kind of cancer. And, you know, again, I just want to be clear, this is not about blame and trying to say, well, these institutions are not doing a good job. But there's something there as to why is it that nearly half the hospitals in this country are treating more white men than black men percentage-wise, right, for intermediate and high-risk prostate cancer. There's only less than 1% of hospitals that somehow were treating more black men percentage-wise than white men. Really small minority, and obviously the other hospitals are in the middle. They treat white and black men equally, but 40% of hospitals were treating more white men compared to black men. I think this is important, right? Because if you consider that treatment makes a difference, and I think most of us here would agree that if you have bad prostate cancer, treatment will make a difference in your quality of life and your life expectancy, and you find that 40% of hospitals are more likely to treat white men than black men, then there's a problem at some level, either on the hospital side, the policy side, the individual physician side, or patient side, but you know, more work needs to be done to understand that. I'm just going to skip this slide. And then this is another study that we did I thought was also providing more info to this question. And this is when we looked, you know, when we talk about there's a discrepancy or a difference in survival between African American and white men with prostate cancer, we often refer to these large registry analyses like the SEER. And what's really interesting is that when you poke deeper and actually look into the data of the SEER, you'll find, as you see here, that the SEER database is comprised of one-fourth of the country in the form of different areas of the United States. And you actually find that there's not that much difference when you account for all these other variables in the survival of African American and white men with prostate cancer. And that's even true for Detroit and for Los Angeles, for Louisiana, for New Jersey. And again, we're accounting for all these outside factors. But one place where no matter how much you account for treatment and all these other variables, Atlanta is distinct because despite all the adjustment, there's a huge difference in the survival between African American and white men, even when you account for treatment and all these other things. So I think that, you know, it does highlight something interesting that maybe we need to put a lot of energy in understanding what's going on in that registry specifically, and trying to understand the difference between that registry and the other places may help us untangle what is behind those differences. If I want to delve a little bit into our work with the Massachusetts Department of Public Health, I do want to point out two things that we found really interesting. For one, you know, when we did these studies, we always thought that we were going to find that certain areas in the state, African American men will do significantly worse than white men. And as a result, we were thinking, okay, well, we're going to invest more energy in trying to understand why certain areas of Massachusetts have worse disparities or wider disparities, and why certain areas have less disparities. What we found was pretty interesting. You know, if anything, when we adjust for all the factors that we know, we actually don't find much difference across Massachusetts, and that's true for all counties. If anything, in some cases, African Americans in Massachusetts, when accounting for other factors, seem to do slightly better. So that's really interesting. And you know, from a policy perspective, you could ask yourself, well, is it because of all the efforts in providing insurance equally across the Massachusetts population have paid dividends, and that's why we don't see this kind of disparity? What's also interesting that I don't point out on this slide is that despite the fact that we have good results in terms of mortality, treatment rates for individuals with, intermediate and bad prostate cancer are still lower across all counties for African American men compared to their white counterparts. So there's definitely something there as to we need to better understand why is it that there's a 10+% difference in treatment rates of African American men with the same kind of disease as their white counterparts. So one of the things that we're interested in, and I'm running slightly above time, so I don't want to go too much into the detail, is that certain hospitals are going to treat the greater proportion of African American and individuals of minorities. 90% of minorities actually receive their care in a really small proportion of hospitals. And a lot of research coming from the Harvard School of Public Health, among other places, has been focused recently on trying to understand, well, if we can figure out why, where are these minority serving hospitals, and try to see what can be done to improve the care at these minority serving hospitals, then maybe we can make a difference for racial minorities as a whole. And this is some of the work that has been done, like I said, from the Harvard School of Public Health, in this case, looking at cardiac conditions and trying to understand readmissions by race and the site of their care. So the framework here is really, again, it is possible that on one side, African American men can go to every individual hospital, the best hospital, the worst hospital, and for whatever reason, their care is not as good. And hopefully that's not the case. And then there's the other hypothesis that maybe care of minorities is concentrated in certain hospitals and we need to invest more energy, either it is money or resources or both, into making sure that these hospitals have the resources to treat individuals of color at a better way than what it has been doing in the past. So we have been putting together a grant. This is currently under review at the DoD to try to look at specifically prostate cancer, trying to see the performance of these minority serving hospitals with regards to treating individuals of color versus individuals, Caucasian individuals, and trying also to understand among minority serving hospitals, is it some hospitals performing better, some hospitals performing worse, and try to understand what's the difference between these hospitals and how we can better understand the care that is provided at such institutions and health systems, obviously. So, I do want to finish my talk on something that I think is also important. Every time I give this talk, especially to a medical audience, people are going to say, well, biology here and there, okay, maybe there's some access to care issues, but one thing that people often don't like to talk about is things like implicit and explicit bias or actual racism, and how we treat, as physicians, how we treat individuals of different race, religion, gender, etc. And I do want to throw this study out there because I think it's interesting food for thought. This is a study that has nothing to do with prostate cancer, and this is for cardiology, so heart attacks, that kind of condition. And they had a scenario that was scripted that a consensus panel felt that these people need to be referred emergently to the hospital to be taken care of because they may be having a heart attack. The twist here is that they asked different individuals of different gender, so men and women, and individuals of different race, so African American, white individuals, and they were reading these scenarios. So the same story, but just told by different people. And they asked medical, personnel, people, doctors, what do you do with this patient? And this study found, and this is hugely controversial, a study cited, I think, 1,500 times, that women and Black individuals were less likely to receive the care that we thought was appropriate here, which is to be referred emergently to the hospital to have a procedure done because we are suspecting that they're having a heart attack at that time. So no matter how much we say, oh, maybe it's something about the trust, how the infrastructure, maybe it's about insurance, maybe it's about financial toxicity, but if you remove all these barriers and you have this kind of story, you ask these people, how do you treat this person? but the person is of a different gender or race, it seems like we do not treat people equally based on this study. So, in closing thought, my presentation is about differences versus disparity. And I think that in the world of prostate cancer, it is a disparity. Often people use those words interchangeably, but in theory, you should use the word disparity when there is some form of injustice. And I think that here, at least trying to point out some of the things, the data that we have been working on and other groups have been working on, I think there's clearly a case of disparities. It's not just biological difference. So thank you for the time to be here. Thanks to Tom for inviting me over. And I'm happy to take any questions at this point.
Dr. Trinh, thank you so much for that wonderful presentation. From your studies that you're doing and from the research that that you've seen in the past, are we getting better or are we getting worse in terms of these disparities in care?
So I haven't talked about, I cited that study that Brandon Mahal did a couple of years ago. I think that people have started looking at the more recent decade, and it seems like the gap is getting better. So, I think my presentation's a little alarmist, but prelim data from, let's say, the last 5-6 years have shown that things are getting better. It's hard to tell exactly why. Some of it could be really the effects of Obamacare starting to trickle in. And other initiatives of the sort. And some people think that it has to do with all that data that Dr. Pomerantz and myself talked about, which is that at least people getting these new drugs, they seem to be working pretty well in African-American individuals. And if they are African-American men are more likely to present with advanced disease and these drugs work better for them, then maybe this is a case where biologically African-American men are responding better to these drugs. But all this is hypotheses. I'm sure we'll know better in the coming years. I would like to point out, and I often say that when I have the opportunity to talk to legislators and advocacy groups, is that I don't think we're doing enough from a policy perspective, right? I think that if we recognize that there's a problem in funding, if we recognize the honest truth that nobody wants to hear, that it pays a hospital, physicians more to see somebody with premium private insurance compared to treating somebody who is uninsured or on Medicaid public insurance. If we don't eliminate that disparity of how we're paid and how we're compensated and how a hospital survives, then we will continue to have problems. And I would hope that somebody with a lot of courage will address these kinds of issues at the policy level, because no matter how much research and how much we talk and how much advocacy efforts we make between ourselves and we educate ourselves, we can't fix this if the policymakers don't make bold decisions to address the problem.
Thank you. I have a couple more questions. One is, let me see, it's a statement then a question. Let me present it. There will be many things to obtain healthcare equity, and it'll take a long time to achieve, but can you share your thoughts, insight, what we can do to reduce the disparity in healthcare access?
Yeah, so I just mentioned the policy side of things. Right. I do think that, policymakers, somebody needs to make bold decisions and actually reward hospitals for taking good care of minorities. So for example, some of you may have heard of things like accountable care organizations that were introduced as part of Obamacare. And they created a list of 31 metrics saying that if you are able to fulfill this metrics, we will reward you. And if you don't, we're going to penalize you. But somebody, an editorialist pointed out at some point saying, well, if we have so many problems with disparities and racial differences in treatment patterns and such, maybe reward hospitals that are providing equal care. I showed you those 40% of hospitals that are not treating white and black individuals equally. Well, if you reward hospitals that do, maybe some of these hospitals will actually take this more seriously because, and again, I'm not pointing fingers, but, hospitals all say that, racial differences is important to them. They care about disparities. They love researchers doing work on this. But, you always want to ask yourself, how much are these hospitals putting effort into addressing the disparities versus just putting up billboards and saying that this is an issue without really directly tackling the issue. Because like I said, ultimately, if there's a difference between race and access to insurance, there will be a difference in receipt of care because, you know, the money flows differently depending on if you're on Medicaid, Medicare, or with, you know, premium private insurance.
Thank you. Another question, is there an explanation of why 90% of African Americans are treated in only 5% of all hospitals?
You know, the explanation is there's so many possible explanations. You know, is it about geographic distribution of African Americans? Where do you live? Where these hospitals are situated? How these hospitals, you know, will identify themselves? You know, I think it's complicated. I think it goes both ways. It's definitely from a hospital level, how it's organized. It will lead to these kinds of discrepancy where certain hospitals are treating primarily white individuals versus other hospitals will be treating a lot of African American individuals. And I think some of it is on the patient side as well. You know, I'm sure that we've heard of all the studies about distrust, mistrust. You know, if an African American doctor is taking care of African American men, if an Asian doctor is taking care of an Asian man or woman, there will be differences. So it's also possible that it's on the patient level. Preferences will lead to different patterns of who's receiving the care and where. And this is not just about you know, race. It's about different level factors, insurance, education, all these other things as well.
Dr. Trinh, thank you so much for that great presentation, and we look forward to continuing to work with you in every way that we can.